Hello and welcome to the EMSNation podcast. I'm your host, Faizan Arshad. Thank you so much for joining us today on this special series done in conjunction with our brand new podcast hosts from EMS World, Josh and Hillary. Guys, I'd love for you to reintroduce yourselves to the audience and tell us a little bit more about EMS World.
My name is Hillary Gates. I'm the Senior Editorial and Program Director for EMS World. So I run all of the content across all three of our platforms, our website, our magazine, and EMS World Expo, which this year will be in Nashville.
Excellent. Yes, and my name is Josh, and I'm the Vice President of the Public Safety Group at HMP, responsible for the EMS brand, EMS World brand. And we're super excited to be here. So thanks again for your invitation and including us.
Absolutely. So this is a three-part series. The first part is with Dr. Manifold on finger thoracostomies. On the line and the current hot seat contender is none other than John Phelps, joining us from San Antonio, Texas. John, I'd love for you to introduce yourself and tell us the extensive amount of work you've been doing leading the PHT, or the Pre-Hospital Trauma Committee, and we'll start to dig in then on all the new updates for PHTLS version 9 and the evidence-based approach that NAEMT employs to the highest quality pre-hospital education.
Sure. Well, welcome everyone. Nice to take this time to speak with you guys today. I'm John Phelps. I'm assistant professor with the University of Texas Health in San Antonio, Texas here. PHTLS course editor for the new 9th edition upcoming PHTLS program and coursework. I currently also serve on the PHT committee, much like you said, where we work together to bring this evidence-based medicine to present across the world.
It's really been a privilege and a pleasure to work with the entire committee. I know that trauma care and education, especially in terms of preventable deaths, is such an important part of our conversation, not only here in the States and on the battlefield, but trauma is a real disease process that folks experience all across the world. Can you describe a little bit about the committee process, what your overarching goals were, John?
Absolutely. So, of course, obviously, we want to try to prevent as much trauma as possible. It is preventable. And so we wanted to take a unique approach, but also the evidence-based medicine that's out there that we gather from all the different organizations that applies to help bring this course together, as well as reaching out to instructors and faculty members and providers, members with the NAEMT organization, to help bring our PHTLS course together. Serving on the committee allowed us to go and look through this research that's out there that's current and up and coming, and so allowed us to incorporate this approach and the new evidence-based medicine into our upcoming PHTLS 9th edition to get this medicine into the hands of our providers so we can get our best patient outcomes and improve those.
I know it was definitely a broad group of folks participating, and you really brought it home for us in terms of the lesson. Just to name a couple of the cast of characters. So for the definitive text on trauma, I certainly think Dr. Andy Pollack's vision of recruiting some of the best and most knowledgeable authors all across the country to create this comprehensive text. Dr. Alexander Eastman, also as the medical director for PHTLS, bringing his extensive knowledge and skill set also from the great state of Texas to help lead this evidence-based guidelines in conjunction with the ACS, the American College of Surgeons. I, of course, served as the EMS medical director, representing the highest quality of evidence-based medicine. And we had a fantastic team of paramedics, including yourself, anesthesiologists, and, military providers, field providers, rural providers, urban providers, to really make sure that this course is able to flex to the needs and demands that, living on the planet Earth as a human being can present.
Absolutely. The way we treat patients in Mexico and the time that it takes to get to operating rooms. And we have those same issues that we in the States as well as in other different parts of the world. And so being able to work with all these different world scholars across the globe has allowed us to bring this information that is evidence-based and put together a course to get to the hands of these individuals across the globe.
So, John, let's get into it. What are some of the things that you're most excited about for PHTLS version 9 and the upcoming launch at EMS World coming up in Nashville?
So I'm totally excited. The course that we have coming up, the 9th edition, in my eyes has taken a total facelift in the way we're going to present the content and the material. And the approach that we're taking has also changed as well. To begin with, we've continued to stay with the ABCDE approach, but we added one step to that, which would be the X in front of it, the XABCDE approach, which would stand for exsanguination of bleeding, airway, breathing, circulation, disability, and exposure. Of course, this is very similar to the March algorithm that the military uses, as well as other algorithms that are out there, CABCDE and seen CABC squared DE. So very similar in that approach. We're still going to focus on controlling life-threatening bleeding. So we added that into the 9th edition to include focusing on maintaining that patent airway and respirations and focusing on breathing, as well as circulation, any type of head injury, spinal trauma, as well as protecting the environmental areas as well as exposure of our patients. To compare, runs very similar with the March approach and the March algorithm. Additionally, going into the case study approach, where we're getting away from the standard lecture where we're implementing case studies throughout the lessons. And with that being said, the case studies will help introduce or improve interaction amongst both instructors and the providers throughout this case study. So not only do we go back and revisit the evidence-based changes, but we also see how it will apply with patient presentations and different various calls that we may see or run on with the different types of trauma patients that we may see. And of course, I get excited talking about it because not only was this course put together by the folks on the PHT committee, but we also were able to reach out to folks, instructors with PHTLS, as well as faculty members, providers that also got to play a role and help with the development of this course to include new patient simulations that are going to be rolled out with the 9th edition that were developed by none other the members of NAEMT and the providers of PHTLS, not just here in the States, but globally. And this is the first time we really got to reach out and we listened to our providers and our members that they wanted to have more of a role play in this course. And so we got to introduce and invite members to play a role, much like Amy Fuller, who's been a rock star, Anthony Harbour, Jim McHenry out of Canada, been amazing. Dr. Pitaloud, to name a few. I mean, it goes even more in depth with the folks that helped us. And so it's really amazing. We got to have split up lessons and have these world scholars come in and assist us with putting the lessons together, case studies that truly hit home, not just to the urban environment, but the rural environment and super rural environments. So it's really cool to implement this evidence-based medicine using the case study approach and in our lecture presentations. We've also got to bring back the skills components. We listened to our members and our organizations as well that wanted to use this course or be able to revisit skills. And so bringing back and being able to hone in on basic life support skills and focusing in on bleeding control. One thing we saw was our providers get to leave and they're able to take this bleeding control course to the public. And so we felt that they really need to have these skills before they leave and hone in on these skills. So we know that we're being very effective with our teachings within the community to help prevent that, to include tourniquets, junctional tourniquets, pelvic binders within our skills, as well as our basic airway skills, to revisit those, as we know that BLS is where it all begins, and truly what begins with saving lives. We also are going to introduce optional lessons. This is the first time we're able to adapt to organizational specific or area needs by bringing these optional lessons to focus in on those areas that really need it, to include wilderness lesson, and altitude lesson, hypothermia, hyperthermia, keeping the kinematics. We're also bringing in ultrasound lecture, which Dr. Arshad, you did an awesome job of putting this together and being able to put this and bring this out to our providers. So allowing the flexible schedule to introduce these optional lessons, with furthermore allowing skills to accompany these optional lessons, or maybe the organization thinks that they need to work on intubation or other areas that they see fit that needs to be worked on within their organization. So the course not only works at bringing evidence-based material at that case study approach, but allows for organizations to focus in on their needs, as well as location and the area needs that they may be working on and implementing, or adding in an optional lesson, or focusing in on optional skills that this course is able to allow these organizations. So I really feel that these folks are really going to be able to use these skills and the information that we provide to them in their best practices and in the field to improve the quality of care. With the new PHTLS updated textbook, we're also going to bring in the course manual to help augment our course that we're teaching. So it's going to have much more of a flow with the lesson plans, not to take place of the textbook, however, but to provide more information, case studies, additional questions, more interaction for the students that'll help them retain the material that we're providing them, but also really engage with the faculty, understanding why we make these changes and how the changes impact the patient's quality of care.
That is a whole lot of information. That is absolutely fantastic. I can't even imagine how long you guys have must have been working on this to put this together. So first of all, congratulations, right? Amazing accomplishment. As a PHTLS instructor, I'm a little bit nervous about how all these things I'm going to have to learn. And maybe you could tell us a little bit about how the rollout of the instructor is going to happen.
Absolutely. So we're going to do a rollout at the EMS World Expo this year. It's going to be in Nashville, which is where we hold our updates. Going to be in Nashville, Tennessee on the 29th of October that afternoon. I could see how it'll be very nerve-wracking. We've got to beta test this new PHTLS 9th edition a couple times, once here in San Antonio to help us hone in on the content and getting it down to the 16 hours. As you mentioned, it's a lot of content and material that we've added and changed to the course, and being able to bring this to a 16-hour course has been very difficult. We got to do that on our first beta test here in San Antonio at the University of Texas Health. And we just recently visited Virginia, where VCU played a part with the second beta test, where we used their instructors to teach the program, giving them feedback or answering the questions that they had. We provided them with the instructor toolkit necessary to run with this course. And I must say the feedback we got from the students from both courses was just nothing but outstanding and positive, which help us build and further add on and help edit this course to make it what it's going to be. And so providing this instructor update, we're going to provide the instructors out there that attend at the EMS World Expo with the material and the content, the changes, and how the materials presented at this EMS World Expo, and be able to address any questions that they may have. And you'll have the PhD committee as well as PHTLS course authors on hand to be able to address those questions and comments, so that way we have our instructors leaving this update with the information and the best material possible for them to leave and be successful with our new 9th edition content. And to be honest, Josh, I really think that these folks are going to leave and be excited, just as excited as I am, to be a part of this change and this growth in PHTLS, to be able to take this program and educate. I think it's something that us as an organization we're looking forward to the most, to being able to see it in action and put a lot of hours in. This course wouldn't be what it is without the team that we have, and being able to put it together. It took a lot of hours and a lot of sweat and tears as went over this program. So we're all excited, and I can sense the excitement from the 2 beta courses that we had, that we're going to get a lot of excitement from the instructors that we're truly putting this course, and not only just the instructors, see organizational EMS directors, fire chiefs that are just as excited, hospital administrators, to see this program be implemented, and the change and being able to adapt to their organizational needs even excites them even more.
John, if I can touch on the part of the instruction that you mentioned, that's really exciting for me as an educator to hear that you're getting away from lecture and really encouraging student participation with case studies. How did that come about? I'm sure that there were students who suggested it, and then there are some who don't want to participate. But from an instructor's perspective, if you're going to tell me that I need to teach with the case study format, what are some of the ways that you're giving tips and tricks to these instructors to make the learning environment more active?
Absolutely. So to come together in AMT, we did a survey a few years ago where we pushed out the survey to address the needs of PHTLS program, what their concerns were. And so a lot of our feedback that we got was just death by PowerPoint, a lot of information, a lot of words on the PowerPoint and on the lecture material. And so we wanted to truly hone in, and a lot of the comments less engaging. And so we truly wanted to find a way to engage the new learners or younger learners, but also adapt to our older learners as well, and keeping mindful that this program has to be able to be communicated across the world in multiple different languages. And how could we do this effectively? And so the team got together, and our best approach was, let's apply this and make this truly engaging, while we'll still present in a lecture format, but to put more, hold the instructor more accountable to be able and provide them with the information to be able to give that feedback and use the students. And so truly how we're embracing that is to see the role play of the case study, where some programs you may see it standardized, where you may see the program being taught where it's a lecture format and then goes into a case study format, whereas this will start off with the lesson objectives, we'll go into the case study. We're just giving them their dispatch information, and then we're leading into the body of our work, if you will, going through the evidence-based material, providing them the up-to-date content, and then we'll revisit the case study. So it allows that interaction while we're still providing that information that is up-to-date, and also revisit some anatomy and physiology content and how it applies and how this works with our changes. And so truly using less words on the screen, where it's going to be more question approach, more so how would you manage this patient, or now that you perform this, what would we do next, or what are our different options. Doing so, we found will also allow our students to expand on their critical thinking thought process. And so be able to expand their critical thinking as well as the applicability from the material that we're presenting to them. So therefore, when we release them to the patient simulations, they will be able to walk in and be able to flow really well in these patient simulations, as from the classroom to that simulation to the skills. We're doing the skills, now we're applying it in the simulation, and then back to the classroom to continue on with the more scenarios and case study approach.
So, John, it sounds like there's a lot of flexibility, and you were talking about anything from wilderness to hypothermia to hyperthermia. One of the things, even before you guys did this kind of expansion, was the integration of both ALS and BLS in a single course. And due to the fact that we all work together all the time, I thought that was a unique approach. Will that be maintained in this new 9th version, where you'll have the possibility of having a hybrid between BLS and ALS and the integration of those teams working together in your scenarios and case studies?
Absolutely. So we'll continue with that transition, and actually we encourage it so we can see the expansion of critical thinking from a BLS level all the way to the advanced level. So it's going to be considered and was put together as a hybrid course to be more of a combined provider approach. So you don't have to have just paramedics in the class when we engage them. We can engage both basic at the BLS level, but also at the paramedic level and that 16-hour time frame. So we're all able to truly engage and learn from each other. The way it's built, we'll be able to learn from the BLS level on the new content that's coming out and the evidence-based procedures and the basics being able to, or the BLS level working with the ALS level, being able to understand why we do what we do, and then we going back and revisiting the BLS level that truly is what saves lives. And the ALS is nice toys and provides us with expanded information that further enhances or improves the quality of care with our patients.
Well, that gets providers so curious, right? I know that we tend to teach all of our classes in a vacuum. So EMTs get EMT and medics get medics, but we don't always train together or practice together. And when we do, people are more curious about what that thing was that the medic mentioned, or that intervention that the EMT brings in from a recent class experience that the medic hasn't seen because they haven't been training on BLS. So I'm really impressed about your ability to not only move EMS forward in the evidence-based medicine approach, but also in instruction and putting us into a realm where we're using best practices in the classroom. That's pretty exciting.
Absolutely. It's very exciting to me as well, just to see in our beta courses, we had BLS level to the ALS, and seeing the camaraderie that they had in working together throughout the course. And many of these folks did not know each other. And so it did encourage these folks to be interactive throughout the course lecture, where a paramedic level, what we seen would be a paramedic go straight to the advanced level, and the BLS being able to hone it down to where we train or change that thought process to, well, no, let's not forget the basics and remember this is where we all started. If this is working, why would we go to the ALS? And many of the times, just seeing that light bulb click in the beta course and teaching PHTLS prior, there's no reason to stray away from that. We learn well together and we all work together as a team. So we did maintain that team approach through and with the 9th edition.
That's a beautiful point. And, just to highlight some of the themes here, at the very first pre-beta in San Antonio, we actually had a team of high school EMTs, and they were literally sitting at the edge of their seats. They were so excited to participate in the course, and certainly bringing the entire team together to say, all right, well, this is the spectrum of care. We're all operating with the same goals. Our intent is obviously to deliver the highest quality care possible to our patients. How can we work together to make that a possibility and a reality? How do we make that actually happen? What are the logistics? And let's practice those heuristics, I may be coming from agency A, you may be coming from agency B, we may have a different scope of practice, but nevertheless, we're all coming together to take care of this single patient who may be critically ill or injured. So let's bring the best skill set and make sure we're really well integrated and deliver effective care. And along those lines, I know Dr. Pittelud, our anesthesiologist on the PhD committee representing the fine country of Switzerland, but certainly an academic scholar and evidence-based practitioner, really focused in on the role of the BLS airway. And I think generally speaking, in terms of national standards, we love the sexiness, the riskiness of endotracheal intubation, but the goal is a lot more than just simply passing a plastic tube through the larynx or the vocal cords. It really starts with basics, and a lot of us are not really well rehearsed or don't really practice our basics nearly as much as we should, and those maneuvers and interventions can really be life-saving.
Absolutely, and to echo Dr. Ashad, we tend to lose that ability as we practice ALS daily, and we forget that we should take a step back and remember our BLS skills to hone in. And seeing our second beta test where we had some EMT students as well and paramedic students that were attending, to see them go back and the advanced paramedics that have been out in the field with experience to all work together and see applying the MPA, and many of us have forgot just simply opening up an airway can solve our problem. So being able to see that within the providers was truly amazing, and Dr. Pidlow's work has just been none other than stellar.
It's been really exciting to see all this stuff on FOAMed about airway, especially about BLS airway, and bagging is a two-person skill, something we were never allowed to do before. Well, not allowed, but certainly not, it wasn't the same way it is now. And making sure we include the NPA or OPA, how important pre-oxygenation is, even with maybe just a nasal cannula. I think the re-emphasis of this, or maybe getting back to the basics, as you said, John, is a pretty important thing.
Oh, absolutely. And being at the our beta in Virginia, the organization elected to also work on intubation. And so we went from BLS airway skills, where they practice those, and to understanding and revisiting those, and to adding in optional skills day 2 to intubation. So they got to revisit intubation. So not only did the paramedics get to work with the BLS folks, or our ALS folks working with BLS, but day 2 BLS got to understand what we're doing with the intubation to better assist us, and maybe be able to communicate with us, with that team, to know when not to advance to endotracheal intubation when BLS care will do the job.
A beautiful point, and I definitely had a case in the emergency department in recent memory at our Janus General Hospital, where we had a critically ill patient who appeared to be septic, and I alerted the intensivist attending while I was attending in the ED. They came down and we were co-managing the patient, and they said this patient needs to be intubated right away. And as most folks know on the podcast, I'm definitely a fan of resuscitation before intubation. And if you are not a practitioner of that, then you can certainly be a clean kill, if it were. So the patient was hypotensive, tachycardic, and I said, this patient needs high quality resuscitation before we actually get started. And actually, it was the entire spectrum of care. The pre-hospital provider had initiated, was unable to get IV access, and started an IO, started volume resuscitation, and in fact started norepinephrine, exercising a medical control option, which I thought was just fantastic and really set us up in a place where we could succeed. And we were able to achieve central venous access. We, in fact, initiated a massive transfusion protocol because we later discovered that it was related to a large volume GI bleed. Once the hemodynamics had been stabilized, basically using, and the airway was a BLS approach, we were ultimately able to secure the advanced airway. But I'm very confident that had I pushed RSI medications, the patient would not have had an optimal outcome. So the sequencing of the care is incredibly important. And I think using real cases from real NAEMT instructors and faculty really changes the whole three-dimensional perspective of this course and makes it come to life, because these are actual cases that you will encounter. And then embedding the education within that, I think, does a tremendous job of ensuring that people actually walk away with actionable skills. When you just throw knowledge and facts at people without a framework to understand or to sort of interpret that knowledge, it's incredibly challenging to, I mean, you might walk away with a certificate at the end of the day, but whether that leads to improved outcomes in your patient population is unclear. As a medical director, one of my mantras is the biggest investment you can make, or one can make, is upgrading the medical decision-making of the practitioners. And I think PHTLS version 9 goes a long way in building that skill set, that sequencing, that medical decision-making for critically ill and injured patients that is without a doubt going to improve trauma care throughout this world. And regarding the world, this was one of the unique opportunities. I remember when we had introduced all hazards disaster response, I think it was at EMS World 2016. And I got up on the podium and was telling all our NAMT instructors about it. There was a large segment from Latin America, and I immediately flipped the switch and started speaking in Spanish, and then somebody was translating for me in English. Building that worldwide collaboration is something that NAEMT decided we must do this. And after having now 2 EMS World of the Americas being held in South America, which were incredible sold-out successes, we certainly are hip to the fact that we can draw on so much talent across this beautiful planet. PHTLS version 9 was a collaborative approach with Latin American colleagues, with European colleagues, with all sorts of folks from North America, Asia, absolutely. So it really is bringing that, broad framework with case studies to the evidence-based approach.
Absolutely. And being able to work with all these folks and seeing it come to light has truly brought us as an organization and the PHTLS program closer together and understanding what's working all around the world. And we all face the same problems, and we can all work together to accomplish our goals in improving patient quality of care in our trauma patients. And so having this opportunity to work with these outstanding scholars across the globe is just truly been a privilege.
I sure would have loved to be a fly on the wall, sitting in a room full of world scholars. That
Right.
sounds pretty exciting. Did you guys have any great stories or anecdotes or tips and tricks from other parts of this world that you heard from them?
Oh, absolutely. So seeing it just, Dr. Arshad mentioned the case studies. So these case studies that bring this course to life are truly brought together and put together by folks around the world that are true cases that those have come into contact with. And so documenting them and being able to put them in our casework is truly amazing. So being able to see how they handled it and how they worked with it and putting it into a lesson is just truly outstanding, and continuing able to bridge that down to the trauma first responder course that we're working on as well with the new update, being able to use these folks from the Middle East and Latin Americas to be able to help us develop a strong TFR course for our first responders. And so just seeing that global response and the collaboration amongst everyone, I can't express enough just how amazing it is to sit with all these folks and the information. When I meet with these folks, I'm a sponge and I just absorb what everyone has to offer all over the world. And it truly is mind-blowing when I initially got into this and began work, is just seeing these folks from around the world have the same problems that we do and never really viewed it or got to look at it that way. And so for us to bring it together for the 9th edition PHTLS, I couldn't ask for a better team to work with.
So I'll stir the pot a little bit. Can we get a behind the curtain view with all these thought leaders and smart people coming from all different parts of the world? For sure, the collaboration was, exuding everywhere. But was there anything, that was somewhat controversial that you had to come to some consensus? Obviously, we're believing in evidence-based medicine, so that will ultimately guide our principle of trying to save the most lives, right? But can you think of anything that during this arduous, process that you all just sort of put your heads together and had to flush out? Maybe you can give our audience a taste of that, maybe.
I think probably the biggest, one of the largest controversies is, of course, the long spine board. And going to a spinal motion restriction, we all know there's importance and a role that the spinal motion restriction applies, and applying the device appropriately and using the most appropriate device for the specific type of injury. And so different views and different opinions on spinal motion restriction and how we do it. And so with the PHTLS 9th edition, we went with spinal motion restriction. We see the need, but keep it open for the organizational specific in which device that you use or your medical director uses and approves, and so allows them to work with that device. We don't specifically go to a single device other than maintaining spinal motion restriction. Dr. Arshad, do you have anything to add to that?
Yeah, absolutely. There was definitely a lot of controversy too. And when you're working in a collaborative effort to try and bring together a combination of evidence-based medicine and best practices, it's going to be an inevitable process. I think another one of the areas that was valuable for me, but also controversial, was determining the algorithm that we use in responding to a critically injured patient. So, for example, I think it was in 2008, 2009 that the American Heart Association switched our well-known ACLS algorithm from ABC to CAB, the circulation, airway, and breathing. And I can recall as a resident training in New Haven, Connecticut in our level 1 trauma center, there were times when I was responding to a level 1 trauma activation where the patient was actively exsanguinating. And, everything stopped at A. They needed to have an endotracheal tube. Otherwise, you could not proceed to B, let alone C, where we would explore that exsanguination and control the circulatory issues which were in effect. And, the spectrum has come so far, and there's been a lot of flattening of the hierarchy. I think one of the breakaways of PHTLS version 9, and I guess the question is this controversial? I do not intend this to be controversial, but was just recognizing that PHTLS and the American College of Surgeons have an incredibly valuable relationship, and there's an incredible amount of collaboration and a lot to be learned. But nevertheless, the in-hospital environment is inextricably different from the out-of-hospital environment. So I think just understanding that the two environments themselves are inherently different, you may not follow the same algorithm you follow in-hospital versus the out-of-hospital, is logical. And I think people ultimately agreed that exsanguination is something that we need to control first. And it's something that, irrespective of your scope of practice, whether you're a civilian or a BLS provider or an ALS provider or a certified first responder or a law enforcement officer, that exsanguination and focus on really tourniquet application, direct pressure, and junctional hemorrhage, etc., was really, if we invested some time, energy, and effort, would lead to a substantial amount of outcome change for our overall generalized population. So that is a whole heck of a lot. I mean, I'm just gonna throw out some of the overall highlights of PHTLS version 9. Case studies, evidence-based medicine, critical appraisals, and the philosophies in terms of our medical decision-making as providers, new algorithmic approaches to the critically ill and injured patient, X, A, B, C, D, E, and of course the March algorithm, which we use in TECC and TC3. A brand new, up-to-date, highly referenced, definitive textbook in trauma care, PHTLS. A brand new addition is the course manual, which is intended to be a supplemental and an in-classroom guide to help facilitate the conversation. And I'm not sure if I'm allowed to announce it, but I will anyway. All of these are going to be going digital, the text as well as the course manual. And the overall cost to the student is going to be significantly decreased. So we are going to be able to get the highest quality materials out to folks at a much lower cost point in conjunction with the strategic partnership with Jones & Bartlett. Case studies, real-world examples from world experts, a whole host of skills from focusing on the BLS airway to optional skills, which allow every single PHTLS course that's taught to be unique, because it really reflects the demands of the students in that room and their local needs. High emphasis on bleeding control, junctional hemorrhage, direct pressure, pre-hospital ultrasound. And that's all going to culminate at EMS World Expo coming up in end of October, beginning of November in Nashville, with the PHTLS instructor update on Monday, October 29th.
Yeah, we're super excited. Our partnership with NAMT has been strong. It's a great relationship, and hosting that is something we're very much looking forward to. We clearly see all the effort and energy, and resources, and that have gone into this, and to have this rolled out at EMS World Expo in October in Nashville is going to be just amazing. So we're really looking forward to that.
Dr. Arshad really hit the nail on the head. It's truly, no other course will be the same, because it's truly unique to the organization is what makes this 9th edition come alive.
John, thank you so much for your time. I think folks are going to be incredibly excited, both current NAEMT instructors and PHTLS instructors, but also folks who are looking for an educational curriculum and platform to really help take their service to the next level in terms of evidence-based guidelines. I think NAEMT offers an invaluable solution to folks all across the world. So thank you so much for your time. Do you have any other wrapping words, comments, thoughts, or things you'd like to leave the EMSNation audience with?
I appreciate you guys having me, and look forward to seeing everybody in Nashville put together, and look forward to seeing this course being taught around the world. So thank you all for giving me the opportunity to be part of this new program, the 9th edition of PHTLS, and being able to work with the fantastic team that I have.
I think Dr. Norm McSwain, the founder of PHTLS, would be incredibly proud of your hard work, John.
Hey, thank you. It definitely means a lot. I know it's hard footsteps to follow. Being able to have known Dr. McSwain and know his passion for the PHTLS community and the trauma community, know he's back there pushing us and watching over us, guiding us as we put forth this 9th edition. There's no other better way to say it, but Dr. McSwain, he had his hands on this 9th edition as well.
And with that, I'd like to kick the mic to our co-hosts, Hillary and Josh. EMS World Expo, certainly one of the best EMS conferences on the entire planet.
One of
the best conferences on the entire planet. So tell us a little bit more about what we can expect. What are some of your highlights? What do you say to the EMSNation audience members who are thinking about it on the fence but haven't registered yet?
Thinking about it, you better hurry up and register. We are going to have the great time in Nashville, October 29th to November 2nd, Monday to Friday, packed with the most important stuff that you need to know to make your practice better, to improve patient care. We also offer operations management, leadership, all kinds of other types of training sessions in the main conference and the pre-conference. We're going to be celebrating the great holiday of Halloween during that week. We'll be doing a really awesome trauma complex coordinated terrorist attack workshop at the Bridgestone Arena where the NHL Predators play. They've loaned us the facility, and we've got many, many other events and activities for you planned, including probably the largest exhibit hall we've ever had. So come see the latest toys and talk to our vendors, and make sure you book your hotel soon.
Thanks for that. Absolutely true. And then really the only other thing I wanted to add is, just as we are really proud and really happy to have the NAEMT, launch of the PHTLS version 9 instructor update at EMS World Expo, the Spanish version, going back to our global conversation, the Spanish version of the instructor update for version 9 of PHTLS will be launched in the 2019 EMS World Americas Expo in Quito, Ecuador. So we're really excited about that partnership and us doing that as well.
Love it. Yeah, version 9 is launching in Nashville as well after 2 pre-beta betas, which I tried to call an alpha. But
Yeah, I was going to say, yeah. One an alpha, both betas, beta 1, beta 2.
You got it. All Hazards Disaster Response is a pre-conference at EMS World Expo, which is a course that a team, including myself, designed for boots on the ground providers, really looking at the medical components of mass casualty and disaster response, which no other course in the world does. So we continue to bring you the highest quality pre-hospital education, and so thrilled to have the folks from EMS World on this amazing episode and podcast. Thank you so much for your time.
Yes, thank you all for y'all's time. And Josh, I hope to see you in your Halloween costume this year.
Oh, wow. That sounds like a challenge. I don't know.
It is.
On that note, this is John Phelps, Hillary Gates, Josh Hartman, and Faizan Arshad wishing everyone a safe tour.